So welcome to today's talk. Excuse the long title and list of names. This is what I essentially want to talk to you about. It's an evaluation of a preventive intervention for children of depressed parents, and it's work that I've done together with Johanna Loechner and many other people in the Department of Child and Adolescent Psychiatry at the University Hospital in Munich. A short plug for our social media channels. We're doing our best to try and disseminate the research knowledge that we're gaining with members of the public and user groups, so feel free to share amongst our channels. And to begin with, I just want to say a bit about why we might need interventions for children of parents with depression. It's really important to know that a child who has a parent who has at some point suffered from depression has a 3 to 4 times increased risk for developing depression themselves, and that equates to around 40% of children having experienced an episode of depression by the age of 20. And that's what you can see quite nicely in this graph from this publication in the American Journal of Psychiatry, that when we look at the age of onset of major depressive disorder, we see this obvious peak around adolescence, and this is much more prominent in children who have at least one parent who has experienced an episode of major depression. And these children are not only more likely to suffer from depression, but also have a more severe and chronic course of depression. And what you might not be able to see quite here is that the WHO, the World Health Organization, has defined the prevention of depression, particularly in high-risk groups such as children with depression, as a major public health issue. What are the theoretical pathways between this risk of depression on the one hand and an actual depressive episode on the other? So what leads these children to become depressed? Well, the most up-to-date model is astonishingly old, was published by Cheryl Goodman and Ian Gottlieb in 1999. But many of the findings are still contemporary. And so what they propose is that having a parent with depression conveys a kind of genetic or biological risk, so that these children of depressed parents have psychobiological dysfunctions. So that might be genes or neural systems to do with serotonin, to do with dopamine, that mean that these children process stressful situations, for example, differently than children of non-depressed parents. There's a biological vulnerability for depression. But what's becoming increasingly well known is that it's not simply a genetic factor, that in fact a number of cognitive, psychological, but also psychosocial stressors play a role here too. So children who grow up with a parent who suffered from depression are exposed to the depressed parent's mental state, this persistent negative mood. They're exposed to the parent's behaviour, so the parent is less available to them. For example, as a result of having to spend more time at home, more time in bed, less availability of the parent. And we often think of cognitions as being something that are internal, that we can't see into or couldn't be inherited, but in fact parents talk all the time about their cognitions. A depressed parent might come home from work at the end of the day and complain about difficulties at work and make statements like, "I'll never be good enough, nobody likes me, nobody takes me seriously, there's no point, I don't know why I bother trying." And these are cognitions which are verbally expressed, but that children can pick up on and teach children how to deal with stressful situations and how to perceive themselves. And for children who have a depressed parent, they're not only exposed to this genetic or biological risk factor, not only psychological factors, but also social factors. So children of depressed parents experience more negative life events, like the separation of parents, than children of non-depressed parents. And so the idea is that these mechanisms lead to a number of kind of deficits in these children which make them more likely to experience depression. So they inherit kind of cognitive styles, ways of thinking about the world that make them more vulnerable to stress. and develop less adaptive emotion regulation strategies. And that's kind of, on the face of it, sounds like bad news, but the good news is, because these factors seem to play such a key role, and these factors are things we can change and do something about, there's a lot of potential for prevention of mental health illness in children of depressed parents. And we recently conducted a meta-analysis of international interventions designed to prevent depression in the children of depressed parents. And two things were quite astonishing to us. The first one was that if you look at the incidence of depression in children of depressed parents who have received some form of intervention versus those who haven't, you see that risk is around half. So children who receive an intervention are around half as likely to become depressed later on as children who haven't. That's on the one hand really positive. But what was quite astonishing to us is that this table here represents 4 different trials. So 4 different trials have evaluated psychological interventions to prevent depression and looked at whether they essentially can reduce depression. 4 trials across the whole world. And that's just not good enough for the thousands of children who grow up with a depressed parent and urgently need support. And so to us, there were some key questions that came out of this meta-analysis that justified the study I want to tell you about today. So firstly, that very few had looked at the effect of these interventions on the onset of depression. Many of them looked to see if interventions like this are effective in reducing symptoms of depression, reducing a BDI score from 12 down to 9, for example. But that's not the key question here. And very few studies have looked at whether effects are maintained beyond the immediate effects after the intervention. So a year later, 2 years later, are the children still benefiting from the intervention? And few interventions have looked at the mechanisms underlying their intervention effects. So we might see that an intervention appears to be better than either no intervention or an active control group, but we don't really know much about why. So that was the motivation for our study. And the clinical relevance of this topic, if in case it wasn't clear to you already, is that in Germany and elsewhere around the world, there are already numerous preventive interventions available for children of parents with depression. Not enough, but there are numerous interventions. They're offered by counselling centres, in schools, various aspects of social services. But what we don't know, which of these interventions are really effective in preventing depression? That children enjoy going there seems to make sense. That they feel like they're useful, I'm sure most of us can agree with, but whether they're really effective in preventing the onset of depression, which is essentially what's needed here, it remains unclear. As far as we're aware, for example, none of the interventions that are implemented in Germany currently have been evaluated in reasonable quality scientific studies. And we don't know how effective they are. So how many of the children who receive these interventions are prevented from becoming depressed? And we don't know what drives these effects. So if it's the case, which it probably is, that these interventions aren't effective in preventing depression in every single child, then we need to modify and improve them. And if we don't know what drives these effects or which children are more likely to benefit from these interventions, we can't improve them. So I wanted to try and persuade you that I'm not some academic psychologist who finds this topic kind of interesting from a theoretical point of view, but if we really want to help children with depression right now, we really need to know which interventions work and why. And before I go on to tell you about our study, I want to briefly introduce you to the work of Bruce Compass and his colleagues at Vanderbilt University in the USA. And the intervention they developed really, we think, has a lot of potential, because whereas some interventions that we identified in our meta-analysis targeted children, so involved children, teaching them coping strategies for dealing with stress, they didn't involve the parents to any great extent. There was maybe 1 or 2 sessions with the parents, but they weren't fully integrated in the program. On the other hand, there are numerous interventions training parents with depression in how to positively parent despite an episode of depression. And the one thing we really like about this program by Bruce Compass and his colleagues is that it's a family-based intervention. And another thing we really like about it, and I think this drives some of the effectiveness of this intervention, and again, there's one reference here, but this has been evaluated across a longer period of time with numerous publications coming out of it. But one really important aspect of the intervention is that it targets the precise mechanisms that have been found to underlie the transmission of depression from parent to child. So it's not about teaching generic psychotherapeutic strategies. It's not about basic psychoeducation, purely what is a depression and what are the causes. It's not about generic CBT. It's really about targeting the risk mechanisms affected by these children. You'll see how exactly it does that in a moment. So the aim of it is to present the onset of depression in children of depressed parents. It's a face-to-face intervention made up of 12 sessions, each 2 hours long, with 4 to 5 families taking part in each group and 2 therapists. And you'll see why 2 therapists are necessary in a moment. And this is what the intervention contents look like. So at the beginning, the whole family comes to the intervention session, and the first 3 sessions are psychoeducation, but from the perspective of this kind of transgenerational aspect. So what is depression? How can I recognize symptoms in my parents? So for children, learning to attribute the irritability of their depressed parent not to their parents' lack of interest in them as a child, but to a very much biological and medical illness. What are the potential causes? So again, here teaching parents the extent to which depression is biologically or genetically inherited, the extent to which they can influence how their children's risk pans out, and really about reducing feelings of guilt amongst the parents, because what we try to say to most of the parents is that they inevitably or most likely have grown up themselves with a parent who's suffered from depression, and they have seen firsthand how difficult it can be. And then after that, although the family comes at the beginning of the session together, they're split up into 2 groups, and the children go into one room, the parents go into the other room, and there's a therapist or a group leader in each of those groups. And children learn, yes, strategies associated with cognitive behavioural therapy that have been scientifically proven to be effective in modifying the symptoms of depression and preventing symptoms of depression. But it's really about using those strategies when there are situations of stress at home involving the parent. So if I come home from school and my mum, who's suffering from depression, is upstairs lying in bed and doesn't want to talk to me, then what do I do? How can I deal with this effectively? Because we know that a lot of children, the older ones, might turn to alcohol or drug use. What we want to teach here is more effective, adaptive, healthy strategies for dealing with that. And with the parents, what we want to teach them is, in a non-stigmatizing way, how can I be the best possible parent I can, given that I'm also suffering from depression? So these parents have it super hard. Parenting is hard at the best of times. And if you're also trying to battle depression at the same time, it can be near impossible. So tips, tricks, how to try and manage that, things that can make their lives easier. And what we always try to emphasize here is the importance of delegating parenting, that a good parent isn't necessarily someone who takes on all of the parenting responsibility themselves, but someone who knows how to build a network around them. If they can recognize there are some things I at the moment can't do and I can't be there for my child, is there a grandparent, auntie or uncle, a cousin who can help me out and to really build a support network there? So the intervention was originally developed in the USA, here by Bruce Compass, and what we did was to develop, adapt it to the German culture, language, and then reevaluate it here in Germany. And we have 3 hypotheses for the study, or 3 broad hypotheses. Firstly, that 15 months after baseline assessment, so a year and a half later, those children who received the intervention would show a lower incidence of depression and other mental illnesses than those who hadn't, and they would show fewer symptoms of depression, internalizing disorders and externalizing disorders. And I won't go into too much detail about the potential moderators of that, but we have taken measures of the severity of pentative depression and the number of life events that children experience, because we expect those to modify the findings. But again, I won't talk too much about those today. What we did want to look at is the extent to which any potentially positive effects of the intervention were moderated by factors that we directly tried to change with the intervention. So coping with stress, emotion regulation, parenting style is something we're trying to change throughout the intervention, teaching parents how to be more consistent with their children, how to show warmth rather than a combination of kind of hot and cold, teaching children about the causes and explanations of depression, and changing their cognitive styles. And some of you might be familiar with the study design already. We essentially recruited 100 families where one parent was affected by depression and allocated those to one of two groups. The control group had no intervention. We call it treatment as usual because that is treatment as usual in the current kind of clinical practice. And those in the experimental condition got our intervention, which is 8 weekly intervention sessions plus 4 monthly booster sessions. And then the families are followed up 6, 9 and 15 months after baseline. I won't say too much about this, but if you're interested in some of the qualitative evaluation we did of the intervention with parents who had participated in the intervention, I can recommend this publication done by my bachelor's student Natalie Klaus. And a preprint that we currently have out is looking at the short-term effects on symptoms. So immediately after the intervention's over, what sorts of benefits do we see there? But what I want to talk to you about today is some data that have freshly been analysed, looking at the effects at 15 months post-baseline, and these data are all in preparation for publication. So as you can imagine, we were quite excited to look at the data and see how the prevalence of depression might vary between these two groups. And based on the findings of Bruce Compass's interventions, we really did expect quite a significant difference in the prevalence of depression a year and a half later. And at first sight, this graph looks quite promising. We see this kind of predicted increase in the number of episodes of mental illness in the children in the control group, less so in the experimental group. But let me tell you something about the scales. We had just 3 children out of the 135 who were included, just 3 of them in the experimental condition who developed an episode of any mental illness, and 6 in the control condition, which is technically twice as much, but with these small numbers and the fact that just under 50% of children even took part in this diagnostic session at the final follow-up, we don't want to place too much emphasis on any statistical comparisons here. So then we were interested in looking at, okay, what evidence do we see that the intervention changes risk of depression as indicated by symptoms of depression and other internalizing or externalizing disorders? And here we got Keisuke Takano from the Department of Clinical Psychology at the LMU on board. And what we did was to calculate multi-level models here to look at the 4 time points. This was really important because we have quite a bit of missing data. So children who have filled out some questionnaires at baseline, but not at T2, then again at T3, but not at T4. And this type of analysis allows for that sort of missing data. And because we've got multiple children in one family, which we want to cluster together. And these were the 3 outcome variables that we looked at. What were then the effects of our intervention on depressive symptom severity? We found no statistical group differences. So, and what this graph below shows you quite nicely is that although the groups didn't differ in the number of depressive symptoms they showed at the final time point, we see quite an obvious decrease here across the 2 groups. So regardless of whether children of depressed parents received the intervention or just took part in the first diagnostic session and then didn't receive the intervention, they show some improvement at follow-up. Not necessarily right at the beginning, but the differences emerge after 9 to 15 months. And these effect sizes are quite large. So here in the control group, an effect size of close to 0.6, which is bordering on large effects. I'll talk a bit more about the end, about why this might be and what this might mean. Then we looked more generally at internalising symptoms, because the literature tells us that children of depressed parents aren't necessarily only at risk of developing depression, but also at risk of other disorders such as anxiety. There's a huge amount of anxiety that these children experience at home. And that's indeed some evidence that our intervention has been effective at preventing internalising symptoms of psychopathology. So we see significant group differences both at 9 months post-baseline and 15 months post-baseline in comparison to baseline. And this effect seems to be driven by an increase in the control group over time and a kind of stability, a trend for a slight improvement in the intervention condition, but significantly, statistically, no change here. And this is the kind of true preventive effect that we're expecting to see. So we're not expecting that our intervention necessarily reduces children's symptoms of depression or anxiety, but more buffers it against an increase. So these children who have a huge risk of developing disorders, that risk goes on as time does. And what we want to do is to stop that increase. And that's what seems to have happened here, at least. When it came to some other outcome variables, we also looked at externalizing symptoms. Does having a depressed parent increase their risk of experience behavioural problems? And that seems to possibly be the case. So we found statistically significant group differences at 9 months, and that seems to be driven by an actual reduction in symptoms in the experimental group and no significant change in the control conditions, slightly in contrast to what we would have expected. But again, these effect sizes are relatively small, and the overall effect size is still a bit modest. So we're a little bit cautious in interpreting these findings, also because they're not necessarily ones that we had strong hypotheses for, but interesting nonetheless. And interesting when we look at parent-reported symptoms. So what parents think the symptomology of their child is before the intervention and after the intervention, we see no significant group differences. And again, let's talk about what this might be to do with at the end of the talk. So then we looked at the potential mediators of our intervention, what seems to be driving this effect. And again here, Keisuke helped us to conduct structural equation modelling where we assumed a lagged effect of the mediator. So for example, that a change from time point 1 to time point 2 in emotion regulation, let's say an improvement in a child's ability to regulate their emotions, would be associated with a change later on in time in their depressive symptoms. And that's what we tested with our model. And actually, I'll start with what we didn't find. So we didn't find any evidence that parenting style, so the extent to which children in the intervention condition, to which their parents had changed their parenting, that didn't seem to affect any changes in depressive symptoms. And we didn't find any evidence for attributional style nor for knowledge of depression. But what we do see is some evidence that reductions in depressive symptoms are mediated by cognitive reappraisal, one of the components of emotion regulation that we measured. Unexpectedly, it looks like this change actually happened in the control group. So I mentioned before that both the intervention group and the control group showed reductions in depressive symptoms. And we might expect here that whereas the reduction in the control group is to do with increased knowledge of depression, because through being recruited to the study, they were more aware of the symptoms of depression. That doesn't seem to be the case. So it looks like actually those in the control group somehow in the course of this time period themselves learnt to increase their use of cognitive reappraisal. And this is a statistical diagram of those effects. I do urge us to be a little bit cautious in interpreting these findings, because when we look at the effect size, they're generally in the small range. Okay, so on to the interpretation of our findings. And like I said, this publication is currently in preparation, so we're certainly grateful for any feedback that you might have on this. Our first finding that we're trying to get our head around is this effect on internalizing symptoms. So this is in line with what we see in the original study, and it is also one of the value of these findings is that it's one of the first to show that these intervention effects hold in the midterm. So it's not just that a child who takes part in an intervention over one summer, after the end of that summer, feels better. It's that a year later they're still profiting from the intervention, perhaps even more so than they were before. And like I mentioned before, the findings seem to suggest a true preventive effect. So we see an increase in the control group, we don't get an intervention. We see that risk rising. That risk is buffered in the intervention group. And what we think these data suggests is that an intervention of this nature might be effective if implemented in the German healthcare system. But we didn't find any intervention effects according to parent-reported symptoms. And some thoughts we've had initially about why that might be are to do with whether this is the function of the fact that most of the parents, or a lot of the parents, were currently depressed. So perhaps because of the ongoing depression, they're less able to feel empathy for the children, to recognise symptoms in the child themselves. But perhaps it's more to do with desirability effects, that parents in the control condition want to feel this pressure to have supported their children in the last 15 months where they haven't received any intervention. In any case, it really supports this concept that we always teach in developmental psychopathology, the importance of data triangulation, so getting data from multiple perspectives. Because if you looked at our trial and we only reported the parent-reported symptoms, you might have the impression that this intervention's done nothing at all, and it doesn't seem to be the case. What we're struggling more to get our head around is these improvements in the depressive symptoms in both groups. So it could be to do with the fact that just the recruitment process alone, just getting children into the lab and talking to them and their parents about depression, about the fact that it is treatable, that alone has an intervention effect. It's perfectly plausible, although we wouldn't necessarily expect it to be as strong, this effect, as a 12-week, 2-hour per session intervention with trained psychotherapists. What's also possible is that it reflects some measurement problems, because the DGPs is the German version of the CDI basically, and has been associated in more recent times with some poorer psychometric properties than we might like. We've ourselves starting to move away a bit from this instrument. So another possible explanation. The fourth finding that we think is quite important is that the interventions show a lagged effect. So whereas a lot of the studies in the past have evaluated interventions in the short term, so over 3 to 6 months, for example, and some of them have found relatively modest findings. And we would urge these researchers not to kind of throw the baby out with the bathwater, to really consider whether these effects of interventions that really substantially changing the way that children think about problems, that might not necessarily have immediate effects, but might only come into play once they experience really seriously stressful events in the coming months or years. What seems to be clear from the data is that the mediators, the reasons, underlying factors that drive our intervention effects are still unclear. So the extent to which the intervention is beneficial as a result of this psychoeducation in the first 3 sessions, unclear. The extent to which changing parents' behaviour has had a positive impact, unclear. The extent to which teaching children coping skills for dealing with depression, again unclear, although in the original trial Bruce found that it was really this child coping skills, this factor here, that seemed to mediate the effects. And because of these findings, we really urge caution in the interpretation not only of our intervention effects, but also other studies. And like I mentioned before, there are studies who have reported quite impressive effect sizes for their intervention, but without knowing what it is exactly about what changes those effects, I think we do need to be a bit more cautious. Nevertheless, quite an interesting finding was that emotion regulation does longitudinally predict changes in depressive symptoms. And coming on finally to the final point, it's really common in this field of research to experience high levels of missing data. So anyone who's done longitudinal research will know that it's hard to maintain people at all time points. Anyone who's done clinical research with depressed people will know that it's particularly hard. But collecting data from whole families where parents are under enormous amount of stress, and their children too, is particularly challenging. And it obviously means that we have to be a little bit cautious in how robust our effects are. That doesn't necessarily mean that the effects are an overestimate of the true severity. It's quite possible that there were parents who may have benefited from the intervention but weren't able to complete data collection. So it's possible they're an overestimate, but it's also possible they're an underestimate. That's obviously a limitation. And before we really get onto the limitations of the study, maybe just want to talk a little bit about the strengths. So this study, as far as we're concerned, does address a really important clinical issue, and that is that there are numerous interventions available in Germany, maybe not as many as we'd like, but there are interventions available which we sell as prevention. But it's unclear whether they work, which ones work and how they really work. And this is not an academic question. This is a really important question for clinical practice. The sample was well characterised at baseline, so it would theoretically be possible to recruit a sample of families where parents simply report themselves that they have suffered from an episode of depression. But in that case, it remains unclear whether it's really depression that is the main kind of clinical focus of the person's difficulties, or whether it might not be a substance misuse disorder, post-traumatic stress disorder, numerous other comorbidities that might actually be more at play here. And it was really important to us that we have a well-characterised sample, that we've got multiple sources of outcomes. I've mentioned that before, these effects in the midterm. And for those parents, I didn't talk too much about acceptance of the intervention today because it's been covered elsewhere, but for those parents who took part in the intervention, there was a really high level of retention. So we think we only had one family who dropped out during the course of the intervention, and that was because they'd moved away from unit. Some of these I've already mentioned, but limitations of the study include the fact that we've got a strong bias towards families with a relatively high socioeconomic status. So families who probably are potentially more resilient anyway, that might also explain these effects that we see in the control group, that a family who's fairly resilient, who finds out they're not being allocated to receive a psychological intervention, has the resources and know-how to go and seek out that support anyway. And it also is a limitation for the representativeness of our data. So to what extent, just because the findings were effective in this particular sample, to what extent does that mean that if we implemented this intervention throughout the whole of Germany, it really would be still effective in preventing depression? We had a number of families in the experimental group who dropped out prior to the intervention. So once randomization had taken place and they found out that it landed in the intervention group, it wasn't the case that all families were super happy about this and immediately took part in the intervention. A number of them dropped out when the kind of reality hit due to quite often time constraints, saying, oh, well, we're really sorry, but we just don't know how we can fit in this into our kind of already stressful schedule. And this to us does say something about the potential implementation of the intervention, that there needs to be some changes made here to the intervention to make it more accessible to more people. Mentioned this before, but the large amounts of missing data reflects the stress that families are under, and it's also unclear whether our effects are over or us underestimating the true effects. And unfortunately, we've got no systematic record of what families in the control group did during this time. I think that could have been really important for us, understanding these effects, the positive effects of the control group that we see according to some measures. So where do we go from this? I mentioned before we've done the translation to Germany, but because of the findings that came out of the qualitative study and also the kind of coincidence of the COVID pandemic, we've decided to offer the intervention, reevaluate the intervention in a shortened form that's then delivered online via video conferencing. And that's part of a much larger project looking more generally at the implementation of preventive interventions for children of psychiatrically ill parents, run by Winogradow in Hamburg. And so the revised version of the intervention is called GUG-AUF Online. It aims to improve the access to the intervention. So we reduced the number of sessions from 12 down to 8. We do that by making a lot of the content available to participants before the session coming up on their mobile device or on their browser. And this also means that during the sessions themselves, we don't have to go through the basics, the psychoeducation basics, what is acceptance, what is cognitive reappraisal, but they've got some prior knowledge and we can start looking at how these techniques might be relevant for their particular family. So if you know anyone who might be interested in taking part of this study, whether it's in our online version of the intervention in Munich or in Bavaria, or more broadly in the ChimpsNet study around Germany, then feel free to send us an email at this address. What do I want you to take away from today's talk? So firstly, it seems that preventive interventions for children of depressed parents can work, but there are a few evidence-based interventions that are implemented in practice. Secondly, that this family group cognitive behavioural intervention shows medium effect sizes on symptom severity, which have been replicated in Germany. but nevertheless the mediators of the intervention remain unclear. So we have a huge need here to understand more about that if we want to develop more effective interventions. And we see a high level of acceptance and efficacy of families who participated in the intervention, but the fact that a lot of families didn't participate in the intervention, it was enormously difficult to recruit these ones who did, suggests that we need to make some changes to how to improve the extent to which this intervention is accessible. And again, I mentioned this a few times, some apparent benefits of the intervention in the control group suggests that even the simple process of inviting a family for a single session, 2 hours, where you give them time to talk about their problems, talk to the parents about the fact that it is possible to prevent an episode of depression and the sorts of reasons why that might be, that alone may have some potentially therapeutic effects. Here are a list of references for that I've mentioned, some studies I've mentioned in the course of my presentation. But that's all I want to say for today, and thank you so much to all of the team who are named here on this slide, who have played really key roles in the planning, running, financing, implementation of the intervention, and the many other unnamed people who also helped us, and of course the families who took part. Thank you very much.